So yeah, basically, I think it's important to understand that the study was designed way back in 2016. So by the time we started to accrue, it was 2018. But at that time, you had the Javelin 100 study, and Avelumab was investigated together with Axitinib in the metastatic setting in a phase 3 trial versus sunitinib. So what we do know is that Axitinib is a quite powerful VEGF-R TKI, which has also shown in other neoadjuvant studies as a single agent to reduce tumors. And at that time, it had not yet transpired that Avelumab or any anti-PD-L1, as to say, in kidney cancer would be of lesser effectivity as in comparison, for example, to nivolumab or pembrolizumab. So that was basically the idea behind it. And at that time, the company was also willing to support us with a limited educational grant. And what we were trying to achieve beyond efficacy is obviously downsizing was the primary endpoint according to RECIST criteria. A secondary endpoint was also safety and obviously disease-free survival, overall survival, and a very elaborate translational research program, which is currently still ongoing. Yeah, very good question. So first of all, that was one of the exploratory endpoints, and as you already mentioned, INMC, so the N stands for Neoadjuvant Melanoma Consortium. And you may say, what has melanoma to do with kidney cancer? In fact, it has nothing to do with it, but it is a very good, let's say, pathological response assessment that you find in the literature that we thought could be used for the assessment in kidney cancer. And it has been established at the Netherlands Cancer Institute where this trial was also performed. So for us, it had added the advantage that pathologists were already using it. Also the response criteria cutoffs. Maybe it's important to point out that in that setting, currently in kidney cancer, we do not have a consensus or an accepted pathological response assessment protocol. And that has been done in melanoma. And what is required to do that is basically that you have at least some association or have been able to show some association with the response, the percentage response in terms of viable tumor cells with your outcome criteria. Now, this does not exist in kidney cancer. And we thought that because in the INMC criteria, you're using these cutoffs. So, for example, major pathological response is defined as at least 10% or less viable tumor cells. Obviously, complete pathological response is complete response. Partial response is 50% or less, and no response is 50% or more. And this can obviously be criticized, but I thought it is important to realize that you need to start somewhere. So you may be aware that many kidney cancers present with necrosis a priori, so that may not have anything to do with your neoadjuvant therapy. That may be a critique that is obviously different in other solid tumor types, melanoma, colorectal. But the importance is that a protocol is in place, and primary kidney cancers tend to be large. So that protocol, for example, requires that most of the tumor tissue is actually being investigated. And the way that's being done is, as I already mentioned, is established at the Netherlands Cancer Institute. What they normally do is the pathologist take the entire tumor and then cut it into sections of, or slices, better to say, macro slices of a thickness of a centimeter. And then each one of those macro slices is then being blocked, and they take the surface of the first blocks. So there's obviously an error margin of, let's say, maybe a centimeter or 0.5 centimeter, unless you would investigate the entire block, but this is very elaborative and very work intensive. And it is one of the best protocols that I consider as being around. First of all, so radiological response was the primary endpoint. And as I already mentioned, the trial was designed in 2016, 2018. And since then, huge strides have been made in technology. So at that time, we were, for example, not planning to do spatial transcriptomics. That was actually an offer that we received from a company that was building their own R&D project, and they helped us out. So a lot of the exploratory markers are actually, um, as I would say, so immunohistochemistry, multiplex immunohistochemistry is long established. But others, for example, like Visium transcriptomics is fairly new. You may be aware that you now even have Xenium, so you can down to single cell level. That's not what we did. We used the Visium setup. And obviously, DNA bulk sequencing, RNA sequencing, these had been established procedures, but you could almost say that it's like a kind of fishing expedition. So you start off with a couple of things um, that you hope will deliver some answers to the diverging clinical response that we're seeing. So the trial was set up. I think it is important to understand that the trial included 40 patients. It's hypothesis generating, and the numbers are still fairly small, although it's one of the larger neoadjuvant studies that was performed. I'd like to remind you that some of the studies included 16, 19 patients. Obviously, we had the phase 3 Prosper, which is far larger than this one. But I think what everyone is hoping when they're doing these trials is that you get some kind of divergent clinical pathological behavior that can then be further investigated with these exploratory endpoints. And one of the, I think, obvious things to go to is bulk RNA sequencing, multiplex immunohistochemistry. And to that, we added, as a more novel technique, Visium transcriptomics. First of all, RECIST is a radiological endpoint, and it has been previously mentioned that attenuation, for example, might be more important than just the downsizing criteria. So you have immune response RECIST that is currently being investigated. I think we had other factors that looked at that also in the TKI era, where the contrast enhancement is actually more important or was considered more important than the downsizing. And because some tumors do come with necrosis, so necrosis is probably occupying some space already. And if it's not vascularized, it's also not to be accepted that it downsizes. Likewise, it has been shown that some of these tumors turn into fibrosis. So I think that it's not an uncommon phenomenon and has also been described in other tumor types. But in terms of kidney cancer, it somehow surprised me a little bit. I thought that we might see at least some correlation, but it is really all over the place. Yeah, pre-treatment, that is a good question. So I think, first of all, that is in so far difficult because all we rely on also in that study was a comparison of pre-treatment biopsy and post-treatment resection material, which is far larger than your pre-treatment biopsy. So I think we are all subject to that kind of bias that all researchers have that rely on biopsies, is that you never know where your biopsy had been. But what we do see is that there's an influx of certain immune cells, most predominantly CD8, cytotoxic T cells. And you can further subdivide them and characterize them. So they may be, for example, exhausted. We used a marker with multiplex immunohistochemistry, which is quite crude, to be honest. There was CD39 plus. They are sometimes in the literature regarded as tumor reactive T cells, but we also know that they may represent exhausted T cell states. Now, that exhaustion would require further characterization, which is best done by single cell TCR sequencing, but that's something that we hadn't done. And then you would, for example, see whether there's a certain degree of clonality of this influx. And if they have, for example, lost PDL1, TIGIT, or LAG3, then they may be in their exhausted states. Now, this in itself does not mean that immunotherapy hasn't worked, but it is another marker that these cells had been recognizing tumor and had been at least um, in exposure to immune therapy. And we have the impression that these CD8, CD39 infiltrates in the tumor post-treatment could identify patients that have better outcomes. Now, we did not find an association with a pre-existing CD8, CD39 infiltrate. So they all showed an increase. And that is very difficult, as I already said. That may be a consequence of the fact that the biopsy is in another area of the tumor. I do have hopes, although that needs to be revealed, it has been described by other groups, and we are currently looking into that, we have peripheral blood mononucleocytes, and it has been described that some patients reveal a burst of a certain subtype of cytotoxic T cells and a certain clonality. And if you can then reveal that these clonal T cells also exist in the primary tumor after pre-treatment, then you could try to find at least an association between, let's say, a very early response under therapy. So not at baseline, but I think if you see in your peripheral blood a clonal T cell expansion of a certain subtype, then this could possibly point towards an immune response. And that would already help us to guide therapy. Because, yes, it's fine that we find, for example, pathological response associated with better outcome, or at least association is a strong word here. I think none of this was statistically significant because the subgroups are small. But you do see that patients who have better outcome do have deeper pathological responses and also a certain CD8, CD39 T cell infiltrate. And also on Visium transcriptomics, co-localization of T cell signatures with the tumors. As good as this is, it is still that you would only find that after you've treated patients for 3 months. And I think what would be the holy grail would be finding something that either, as you say, predicts that pre-treatment or at least very early on in the first maybe 1 or 2 weeks of treatment in the peripheral blood. If you do see, for example, a clonal expansion, as I mentioned, which would then correlate with your outcome, then you could use that as a kind of predictive early on treatment marker.